Welcome viewers to Morning Grounds, Morning Rounds, Stony Brook Medicine's video series designed to bring together leaders, faculty, and staff for candid conversations about key initiatives and innovative work across our health system. Today, I'm delighted to introduce Dr. Joe Verghese, the new chair of neurology at Stony Brook Medicine. Dr. Verghese is a world-renowned expert in the effects of aging on cognition and the motor system, whose research has shaped the understanding of dementia and its early detection. His recent groundbreaking study, published in Nature Medicine, was recognized as one of 2024 NIH Research Highlights of the Year. He's the developer of Five-COG, a culturally unbiased cognitive assessment tool designed to improve dementia diagnosis in diverse and busy primary care settings. We're excited to dive into his vision for the department, his groundbreaking research, and the future of neurology at Stony Brook. So, grab your coffee, settle in, and let's get started. So, welcome, Dr. Verghese. Thank you for joining me today.
Thank you, Dr. Wertheim. Thank you for having me here today.
It's a pleasure. Tell me a little bit what inspired you to come to Stony Brook and join us as the chair of the department, and what are some of the key first steps as part of your vision for the Department of Neurology?
Well, I've always believed in change, and approximately every 12 years in my life, I've made a change. 24 years ago, I was working in the United Kingdom when the research bug hit me, and I decided to move to the United States to pursue my clinical research training and interests. 12 years ago, I had an unusual opportunity as a neurologist. I was asked to be chief of geriatrics, and I believe to date I'm the only neurologist who's led the division of geriatrics in the country. So a couple of years ago, I think I felt I've achieved what I had to achieve, and I stepped down as chief of geriatrics, and I was looking for the next opportunity when this opportunity at Stony Brook came. When I learned more about the place, I got really excited because I admired the vision to provide compassionate care to patients in Suffolk County, Long Island, and beyond, to engage in groundbreaking research, and generally to improve health of older people as well as the general population. So these are all ideas that resonated with me. I was very impressed by the leadership here, yourself, Dean Igarashi, Ms. Gomes, and I shared your vision to take Stony Brook to the next level. So this is what excited me and brought me here. I was also very lucky in that my chief supporter in life, my wife, Felicia Ambrose, who's a rehabilitation physician, wholly supported the decision, and she herself has joined faculty at Stony Brook. And 5 or 6 of my key members of my team also joined. So in many ways, it looked like I was bringing home to Stony Brook, and it was a very welcome introduction to the Stony Brook community.
That's great. Well, we're delighted to have the both of you here, and your whole group of faculty that you brought over with you. I'd like to start off a little bit by talking about some of your research priorities. First, maybe you can talk a little bit about the Five-COG test, what it means in terms of a tool, and what some of the key findings in your research have been regarding that test.
Sure, my pleasure. As you know, there's an aging tsunami that's occurring within our country as well as globally. And a major concern for people who grow older is cognitive concerns and what that might mean to them in terms of, is this the first signs of cognitive impairment or dementia? Most older adults get their care in primary care. Mm-hmm. And so most older adults who have cognitive concerns are seen in primary care settings. Unfortunately, in the primary care, there are many barriers to these patients getting adequate care and management. Primary cares are busy. An average primary care physician has about 15 minutes to see a patient. And in that time, he or she has to deal with about 6 medical issues. So often there isn't enough time to address issues like cognitive concerns. About 1 in 3 older adults who comes to primary care has a cognitive concern. But the statistics say that about 80% of cases of dementia are underdiagnosed or undiagnosed in primary care. So there's greatly a need to better manage patients with cognitive concerns. The National Institutes of Health recognizes this as a public health priority, and they put out a request for applications for approaches to deal with older patients who present to primary care with cognitive concerns. And we were fortunate that we were one of the 3 sites in the country that was selected to test out our approach. The other 2 sites were in San Francisco, UCSF, and Northwestern in Chicago. Mm-hmm. Our approach was to develop a 5-minute cognitive screen, which we call Five-COG because it only takes 5 minutes to do.
Good name.
And yes, there's something about getting catchy names so that it sticks. But honestly, that was just a filler name that we picked, and I thought somebody else would come with a better name, but Five-COG it is for posterity. In any case, the Five-COG consists of 2 picture-based tests. We chose pictures because they overcome limitations that people have who have low education or illiterate. And at that time, I was working in the Bronx, and we had a large population of people who had low education. So we had to deal with this. So giving pictures avoided the need for people to read. They could just identify the pictures and do the test. Mm-hmm. The third part of the test is over the last 2 decades, one of the focus of my research has been identifying gait disturbances or slowing of gait as an early marker of dementia. So we used that knowledge to come up with a third test, which was just getting people to walk a fixed distance. And if they walk slowly, then in the Five-COG, that's considered abnormal. Now, there are thousands of cognitive screens that have been proposed, and I'm sure there'll be thousands more that come out. And the difference with the Five-COG is we paired the tests with a set of recommendations that were available in the electronic medical records. And importantly, the test wasn't given by the primary care physicians, but they were given by community health workers based in the clinic. So this reduced the burden on the physician. Once the patient got the test, then the results were forwarded to the physician on the electronic medical records. And these were not prescriptive. These were just suggestions. The physician could choose to follow them or not. And in lots of cases, they chose to use their own judgment because, after all, this was just a 5-minute screen. And many of these patients were very familiar to their primary care physicians who had been following them for many years. We did a clinical trial based in the Bronx, and we were able to show that in the arm that received the Five-COG, we improved dementia care by about 3-fold. And by improving dementia care, what we meant is there were more diagnoses of dementia and mild cognitive impairment. Patients were sent for the right screening tests for cognitive impairment. They were receiving the right treatments. They were being referred to specialists for the right care. And as for the diagnosis itself, the arm that received the Five-COG showed an 8-fold improvement in diagnosis of mild cognitive impairment and dementia. The results were really stunning and spectacular and so strong. I think based on that, NIH has actually funded us even before the clinical trial got over to do a follow-up trial. And currently we are doing a cluster randomized clinical trial that involves 22 primary care sites. We have 6 clinical sites in the Bronx, and we're partnering with Indiana University. My co-PI is Dr. Malas Bustani, a geriatrician, and they're contributing 22 primary care sites. Half of them would get the Five-COG, and half of them would be usual care. And we are 3 years into the study, and hopefully in another couple of years, we can come out with the results.
That's fabulous. I think one of the things that makes it so powerful, speaking as a primary care doctor, is that one is very busy and one is trying to manage a whole variety of different problems in primary care. So having somebody flag a validated test that shows that there may be a cognitive issue is so helpful and really helps direct what you're going to do in a short visit or a series of short visits. And I think, from the receiving end perspective, I think that makes it so useful as a test. What sorts of areas in research do you envision the Department of Neurology to start thinking about and exploring over the next couple of years?
Clearly close to my heart is issues of aging. And among the issues in aging, I think there are a few big geriatric syndromes that I think impact people from a neurological perspective. Cognitive impairment and dementia are clearly one of them. But there are other diseases like traumatic brain injury, epilepsy, strokes, and all of this, I think, require attention. So my focus is to start from my home base and develop programs in aging that focus on cognition and gait. Over the last 20 years, we've shown that both of them are highly related. Gait disturbances are an early marker of cognitive impairment, and people with cognitive impairment tend to develop gait disorders. And both together lead to a number of other geriatric syndromes like frailty, falls, which is a big concern among older adults. About 1 in 3 older adults fall, and if you fall once, you're highly likely to have another fall. I think it was Gabriel Garcia Marquez who said, old age comes with the first fall. So it is a very dramatic and impactful event in an older person's life to fall. So we are developing programs in our research to try and understand what are some of the cognitive causes for falls and how can we intervene by either targeting cognition or trying to improve gait and balance. Many of my questions have come from observing the patients that I see. And I've got a lot of insights by the patients that I've seen over the years. For instance, one thing that I've noticed many years ago is that once I was following 2 older ladies into one of our office buildings, and I noticed that they were engrossed in conversation, and when they got to the door, they were so much engrossed in conversation, they couldn't disengage to initiate the motor function of actually opening the door. So this observation stuck in my head. And I also came across a study at the same time done by a Swedish physiotherapist, London Olsen, where she said that nursing home residents who were walking and talking in the nursing home were at high risk of falling, because walking and talking is a cognitively demanding task. So we developed a walking while talking test, no chewing gum involved in it.
Thank goodness.
But we found that people who slow down while walking and talking were at high risk for falls. But interestingly, that this test is it's a parallel to what cardiologists do with EKGs and stress tests. So someone might have some cardiac disease, but it might not be overt. They might not have any symptoms. But you put them on a treadmill and measure what's happening in their heart, and you come up with early cardiac changes. So the walking while talking test is a similar mobility stress test in that somebody might be walking normally, but then if you stress them by asking them to walk and talk, and in our studies, we typically ask people to recite alternate letters going from A to C to E. So this is a difficult task. Even normal older adults or younger people slow down. But if you slow down by a third or actually have to stop while walking, then that suggests maybe there's some cognitive or gait issues going on. So that was one of the examples of the tests that we've developed based on clinical observations.
Well, that's great. And I love the analogy to a stress test, that you're looking at the actual function of an organ while somebody's exercising or doing something different that might stress that organ. So I think it's a great analogy. I want to turn to your clinical vision a little bit. So we have a robust clinical enterprise in the neurology department. We have some key strengths. Tell me a little bit about where you think we can build, or what you think you'd like to sort of add to what our existing strengths.
Sure. I guess I'm very fortunate that I'm inheriting a department with such strong clinical strengths. So we do have strong programs in epilepsy, in stroke, multiple sclerosis, neuromuscular disease, to mention a few. And clearly, we need to strengthen these programs. There's a greater demand for all these diseases, and the population, especially in Suffolk County, is growing older. And so there's clearly a need to increase the amount of stroke services that we provide, seizure services that we provide to both adults as well as children. But also want to build a department in areas that we really haven't had a great strength in. Neurological diseases contribute to the major portion of disability in the population. And probably the biggest contributions come from Alzheimer's and other cognitive impairments, traumatic brain injury and spinal cord injuries, headaches, strokes, and seizures. So we do clearly have strengths in strokes and seizures, but we do need to build strengths in these other areas where currently we do have neurologists who attend to these diseases, but we don't have focus centers. Right. So close to my heart, I do want to build up our cognitive neurology program. I'm fortunate that it was one of my first hires as chair is a cognitive neurologist who's joining us later this year. Mm-hmm. And we will partner with the Department of Psychiatry, which has a center of excellence in Alzheimer's disease. And I think this is a tremendous opportunity to work across departments to serve the needs of people with cognitive concerns, provide access to the latest diagnostic investigations as well as treatments. In the area of traumatic brain injury, I have an inside weapon. My wife is a brain injury specialist, and we've created with your help and Dina Garashi's, a new division of neurorehabilitation. And she actually started her first clinic just this week.
Oh, wonderful.
So we officially have a clinic for neurorehabilitation where the focus will be on patients with traumatic brain injury, people with gait and balance problems, and people with spasticity and other pain conditions. So we do want to build that program. We would like to hire more physiatrists to serve this need. I think we could also not only have an impact on the outpatient, but there's a great deal of requirement in creating rehabilitation pathways in the hospital for patients admitted with not just neurological diseases, but other serious illnesses, so that we give them optimal care in hospital and also have a clear pathway for their discharge into settings where they can continue getting rehabilitation and other services they need. I'm excited that we're also looking to hire a headache neurologist so that we can serve our local community better by having a dedicated headache clinic. Mm-hmm. So these are some of the directions that I would like to take the department into. And I think by doing so, we serve not only local community in Suffolk County, but it will also be centers which would attract people from other parts of Long Island and New York.
Absolutely. I know we've spoken before about the need for more people who can take care of individuals who've had traumatic brain injuries. So I'm delighted to hear about your plans. What about, I do want to ask you directly about the stroke service, because that has long been really one of our strengths. We have the mobile stroke units, and we have a vascular neurology educational program. Where do you see the future as it pertains to stroke?
I think the unfortunate side is the stroke epidemic is here to stay. Mm-hmm. I think it is clearly a public health challenge to change lifestyles in order to get people to exercise more, have better care of the diet in order to downstream prevent strokes. So I think we will be dealing with strokes. We have a wonderful service right now, both in our hospital setting as well as out into the community. I think one of the challenges we have in Suffolk County is a geography. Mm-hmm. We're spread out far. We have only a few highways, and if we expect all patients to come to Stony Brook, they don't get optimal care. So even before I joined, I think the initiative to have mobile stroke services, have ambulances that have imaging and the facility to actually start acute stroke treatment, giving clot-busting drugs on the road, I think is a game changer. And clearly we need more of that.
Yes.
I think we need to strengthen our affiliate hospitals in terms of the stroke care they provide. We are collaborating with Southampton Hospital as well as Eastern Long Island to improve the stroke care that they can give locally.
Mm-hmm.
I'm looking forward in the next month. I'm planning to go and visit both of these sites locally to better understand not just their stroke needs, but the other neurological needs. And I think if we strengthen the system, I think we benefit as a whole.
That's great. Since you talk about the affiliate hospitals, one of the things that I know we have thought about with respect to other specialties are things like telehealth, teleneurology in this case. How would that, or maybe any other innovations, technological innovations, do you envision helping the care that we deliver?
I think teleneurology or telehealth is an important addition to the services that we bring. We probably saw the greatest use during the COVID epidemic when patients couldn't come into hospital settings or clinical settings, and there were a limited number of medical professionals who could go out.
Mm-hmm.
I think some of the stroke services we provide lend themselves to teleneurology. And indeed, on the mobile stroke service units that we have, teleneurology is an important part. The EMT technicians consult with our in-house neurologists to make sure that the diagnosis is appropriate and that the patients are suitable for clot-busting drug treatments. I think there is a possibility of extending teleneurology to geographically isolated areas so that we serve patients who are geographically isolated.
Mm-hmm.
And I think this definitely would be a part of the services we provide.
That's great. Great. Very exciting. Academic medicine is always three parts of a stool, right? There's research, clinical, and education. So we haven't touched upon education quite yet. Tell me what your perspective is on education within the Department of Neurology, some of the strengths, and where you might think about taking the educational programs.
So we do have a strong neurology residency program. We take 6 residents a year, and we do have fellowship programs as well. For someone who's considered a researcher, actually think the primary purpose of a residency program is to give you good clinical skills. So I think the foundation of a good neurology residency program is one that teaches good clinical skills and uses that as a foundation to use technology appropriately and plan management. So a focus area that I have we have a new program director who's joined us, Dr. Siliotsky, and with her assistance, we are trying to build in clinical experiences for the residents, make sure they are exposed to the different subspecialties within neurology, get the depth of exposure to the basic bread and butter neurology, like strokes and seizures that they need to know, but also see some of the more unusual cases. I believe a residency program should have a strong academic background. So we are providing opportunities for residents, as well as the medical students who rotate with us, the opportunity to take part in research. One of my colleagues, Dr. Helena Blumen, who joined me in this institution, was appointed as vice chair for research, and her mission is actually to increase research activity among residents as well as medical students. Mm-hmm. And I think there is a spillover. I think if we have a strong educational program, the faculty get involved in it. And when the faculty get involved in it, that translates into better evidence-based care into clinical practice, as well as interesting research questions that we can take forward. So I see this all as a continuum, that one feeds on the other. And when one is strong, the other part gets stronger too.
That's great. I think a lot of students and residents are overwhelmed by the idea of doing research. And I think it's so helpful to have a story like you told about watching the 2 patients of yours walk and be unable to open the door because they were having a conversation. That idea that it's a simple observation and wanting to explore that a little deeper can be the root of some really exciting research. I think that's a powerful example to share with people who are learning.
Thank you.
A little bit about your origin story. What made you interested in neurology as a field? How did you come to that?
Well, that's a long story, but the short version was that so I was the eldest son of a businessman, and family tradition is that I should have followed my father into business. But he saw that I was interested in academics, not particularly in medicine, but just I was good at school. And he said I could choose my own path. But his only advice is whatever you do, make sure you do good. And I landed up in medical school, and I wasn't particularly interested in medicine. But then I came across neurology almost by accident. And it just fascinated me. It's one part of medicine where the art and science of medicine come together. It's one of these fields where observing a patient, examining them, leads you into insights that technology can't always replace. There's a feeling that neurologists rely entirely on MRIs, but I beg to differ. I think a proper history and exam often gives insights that sometimes even an MRI cannot provide. So that led my interest into neurology. And later in my training, when I was in England, I had the opportunity to spend 6 months in a geriatric unit. And what interested me about older people was in my first case, which was an older lady who was brought into our inpatient setting. And she was just agitated and was restless, couldn't stay still. She was physically aggressive. And then we discovered that she had a urinary tract infection, and that was leading to delirium, which was the syndrome she had. We treated the urinary tract infection, and hey presto, the next day, it was the sweetest old lady, and it was such a dramatic change that I was so amazed that such a small thing, a minor urinary tract infection, could affect the brain and cause a personality change that was so dramatic.
Yes.
That led I think that's what led into my interest in issues of aging, and especially neurological diseases that manifest in aging. And of course, cognitive impairment and mobility impairment are probably the most important. I guess what's ironic is that my father's business is actually making footwear. So in a way, my interest in gait and walking led me back to the family business, but in a different way.
I'm sure that if you went back to a footwear store and watched people try on shoes, you could probably identify those who might have a little cognitive decline as they test out their new footwear walking across the carpet.
I do. Incidentally, that's what led to one of my earliest insights. I was a study clinician for an aging study early when I was a junior faculty. And I would examine hundreds of older people. And just to keep my clinical skills sharp, I would examine them and try to conclude whether they had some mild degree of cognitive impairment. And when I finished my exam, I would go and talk to the neuropsychologist who had done a more detailed cognitive battery and compare my exam with the neuropsychological detailed cognitive testing. And I started observing that older people who had difficulty walking, often enough on their cognitive tests, performed poorly. And this led to the idea that maybe we could use abnormal walking patterns as a predictor of dementia. And it turned out that in that particular study, older adults who had neurological gait abnormalities due to things like strokes or Parkinson's were twice as likely as older adults who had no gait abnormalities to develop dementia. So I guess another example of clinical observations leading into insights into disease process.
I think it's a wonderful explanation as to how you ended up in the career that you did.
Thank you.
So thank you so much, Dr. Verghese, for joining us today and sharing more about your plans for the future of neurology at Stony Brook Medicine. And as always, thank you to everyone at Stony Brook Medicine for everything that you do to make a difference every day. Until next time, keep the coffee brewing and innovation flowing at Stony Brook Medicine.